Welcome to another episode of the recorded virtual Global Spine Conference. Today we welcome Dr. Jonathan Rasouli from the Cleveland Clinic discussing a case of cervical spinal deformity. Enjoy.
So the patient is a 42-year-old lady who presented to us roughly about 2 or 3 o'clock in the morning after being hit by a car. She had a past medical history significant for active IV drug use, hepatitis C, and she had a pretty significant history of tobacco abuse as well too. On examination, she was inebriated. She was following commands in 4 extremities. She was complaining of axial neck pain, and she was in a hard collar that was placed on the field. And although it was hard to get because her exam was effort and pain limited, it did appear that she had some weakness in her hand grip bilaterally. We, as part of a trauma scan, she got a CT head and essentially pan spine. I'm showing some of the images here. Unfortunately, we didn't have a good cervical lateral x-ray, so I put up the scout, but you can already kind of see on that where we're headed towards in terms of our pathology. And then you have a sagittal CT non-con and coronal non-con as well too. These are just kind of the midline views. And the read on this, again, this is the 2 a.m. read, was that this was an acute C3 for traumatic burst fractures with retrolisthesis of 3 on 4 and possible spinal cord compression. And if Dr. Gibbs, if you're still here, she's our expert neuroradiologist. I'm just wondering what you think about the appearance of this. Does this look like a classic burst fracture to you? Is there anything about this that seems a little bit odd?
Yeah, this is a fantastic case, John. Everybody hear me okay? Your scout view right away tells you that something is going on. This is a nice picture. I don't know if you can see me controlling the arrow, but prevertebral soft tissue swelling, too much, even if you can't see the bones very well. So as radiologists, we know this is either going to be trauma ligamentous injury or it's going to be infection. Your CT really shows the whole story here. I think your 2 a.m. read must have been somebody that was still asleep, maybe reading from their cell phone or something. So this is a nice picture for many reasons. So on your sagittal CT, you still have too much soft tissue swelling, not as much as on the x-ray. But you have some other features which I know you've picked these images very intentionally because it shows exactly what's going on. You've got this deformity and collapse here at C3, C4. Really, this kind of deformity, this is not a fracture. I know we'd have to look at the axial images, but there's no fracture here, and you can tell. This end plate irregularity, which you see on the sagittal as well as nicely on the coronal, really tells you exactly what the diagnosis is. Sometimes you see this kind of degenerative remodeling in degenerative disease, but in this case, we know it's not because of that end plate irregularity. And one more little pearl here, and I'm going to turn the case back over to you, is this sclerosis diffusely throughout the vertebral bodies. That's something that not everybody looks at. That would not happen in trauma. This picture is going to be of density within these vertebral bodies. It's either going to be a marrow process like edema, or it's going to be cancer. Sclerotic Mets or lymphoma. And we're not looking at lymphoma. We don't think this person has cancer. So even in these pictures, you know what's happening, and really you don't even know. You probably don't need an MR, but maybe you have one.
Yeah, excellent points, Wendy. It did, just even at 2 o'clock in the morning, kind of dealing with this consult as the chief resident there, you don't really, you kind of, doesn't look like a classic traumatic fracture. It doesn't really look like something that, it looks chronic. And there's some suggestion, especially with the erosion of the end plates and it's kind of a chronic appearance. And she certainly had a past medical history that increased her pretest probability of this being potentially something infectious. So I don't know if anybody would have just gone ahead and taken, so this is a lady who's potentially weak. She may have some, maybe a spinal cord contusion just based on this. Would anybody get an MRI at this point, or would they just go ahead and take her to the OR? Or?
Yeah, I'd get an MRI for sure. I think as Dr. Gibbs is alluding to, we're, and you as well, we're strongly suspicious of, osteomyelitis cystitis here.
Yeah.
And I think an MRI, especially in a patient who's relatively intact with the exception of the hand pain, certainly would only be helpful to us.
Yes. Exactly. That's exactly what we did. So we ended up getting an MRI. We planned to get this with with and without contrast. Unfortunately, she did not tolerate the contrast portion of it. In the interest of time, I'll just go through it quickly. But what you see here is very highly suggestive of infection. You see there's pretty significant prevertebral soft tissue swelling, edema in the soft tissues here. There's a significant bone marrow edema, potentially even a phlegmon here on the T1 and T2 images, and it's stir signal change all throughout. So based on this, out of curiosity, just again opening up to the floor. So would anybody not operate, and if you're going to operate, is it going to be front only, back only, or front back? Anyone want to chime in?
Yeah. So Jonathan, I think this is a really good case. It's very common, one that most people have to be familiar with treating, and I think you're right. The MRI was definitely a good idea. The question is in addition to this, what are her or the patient's active comorbidities in terms of cardiac issues, cardiopulmonary issues? I think for a lot of us, that dictates when you take a patient back to surgery, depending on the severity of the neurological deficits. So what's her overall medical status? When can she tolerate surgery? What's the soonest you can tolerate it?
So she, you can imagine that she was pretty frail. She's a lady who's had a lot of issues with prolonged chronic drug use, malnourishment, but she did not have any active cardiac or pulmonary issues. She was pretty stable from that standpoint.
Got it.
John, great case. I'll chime in first. And, just scrolling through the chat, there's a lot of votes for front back. I would treat this all posteriorly, and I'd be interested to see what others think. I think posteriorly you have the option to get a really excellent decompression at the stenotic levels. You can, for me, I would probably fixate this C2 to C5. And then I think with the treatment of antibiotics, the anterior portion has a very strong, very high likelihood of ankylosing. I think the problem with approaching this from the front is that once you get high up into the sort of the C2 area, you might start increasing your chances of different complications from upper cervical exposure. So my vote would be C2 to C5, laminectomy and fusion. But I'd be interested to hear what the others have to say.
Yeah, this is John Shin. So I think that's a great point, and I'd be interested to hear what Wendy has to say, because there is a lot of literature and I think data within orthopedics about stabilizing like infected joints and things like that. And I think that here you have to think about the morbidity of the anterior approach, high cervical approach in this person who is probably not the most compliant person and what the goals are. I think that along with Coy's point, I think with stabilizing across that area between C3 and C4, that area will probably fuse on its own. And it's not so kyphotic that I would think that you need to necessarily resect all of that. I mean, that would definitely make the CT look better. But I would agree with Coy. I think I'd like to get some x-rays to see what the alignment is weight bearing, but I think that posterior approach, that's what I would favor.
What are some of the participants asking here?
Can I ask a question real fast while you're looking at the questions? Does it matter what kind of infection? Because from this picture, we don't know, right? Or did you already say, John, what it is?
Well, we don't know what kind of infection. We don't even know if it's infection yet.
Oh, okay. So I know it's infection. So I would give you that report that it's infection. But but you don't know whether it's pyogenic or whether it's something like tuberculous. And I'm wondering if that would make a difference whether you actually do more or less. Because somebody, I think Coy said antibiotics would treat the front. Without a contrast, we don't know whether it's phlegmon or abscess. That's another question. All of those things. I'm wondering if all that matters to your surgical decision making.
Ali, to your question, there's a lot of comments about more of an infectious workup, and again, just more sort of votes in favor of a front back procedure.
Yeah, those are great points. And Wendy, to your point, I think if there is evidence of structure. I mean, certainly if there's neurological deficit, if there are neurological deficits or structural instability, and it seems that there's both here, right, Jonathan?
Right.
Yeah. So I think regardless of what the potential pathogen is, or organism, or what type of infection, you're probably looking at a decompression and stabilization procedure for this patient. Whether you go from the front or back or front back, I think that's definitely up for debate. In general, the teaching is that if there's good alignment or good lordosis, you can go from the back. If there's kyphosis, you go from the front. Those are just general principles. But one thing, and I'm interested to see what others think, one thing I've never regretted is being a little bit more aggressive with these infections in terms of stabilization, so that you don't have to come back later for what would be otherwise a difficult revision.
And that's one other thing. I have a great case that it was kind of not as revealing on the initial images, but it ended up being many more levels than they originally thought. So that's another reason I'm wondering if like the length of your surgery might be different, depending on maybe more imaging. And again, the pathogen, maybe that enhancement goes down farther. Maybe there's epidural abscess down farther if we had a contrast scan. Would all those things make a difference as well?
Yeah, no, definitely, absolutely. That's why unless there is a contraindication to MRI, I think it's an absolute must to get an MRI to see exactly that. What is the extent of the epidural component? How rostral and how caudal does it extend? As well as what the discs, adjacent discs and adjacent soft tissue looks like.
Yep. These are all excellent points.
Hi, everyone. Hello.
Yeah.
Ali. So when I look at this, my inclination is to go either back, front, and back, or just front and back. The fact that on MRI, she has more time to reduce. If you look at that C2 angle, probably I will go to the front first and then to the back. I don't think by just going through the back, my experience is limited, but doing that wide laminectomy and that C2 par screw is going to be strong enough to hold her.
Yeah, Puya, that's exactly our reasoning as well too. We were concerned about the degree of ventral compression from this kyphotic deformity here. We wanted to be able to get, there was a high suspicion for osteomyelitis discitis, so we wanted to get a bug. So we decided to do exactly as you said. I'll show you the post-op images. We ended up doing a front back. We did a front portion first. We did a corpectomy of C3-4. There was some discussion, Dr. Tan, as you mentioned, there's with these high cervical approaches, especially when you are close to C2, there's a risk of pretty significant risk of postoperative dysphagia. So we knew we were going to go posteriorly, so we were going back and forth whether or not we would use an anterior plate. We were thinking of just putting the corpectomy cage in by itself and then just going posterior, but ultimately we decided to use a plate. And then we fused her from C2 down to C5. And we did not do a decompression posteriorly. All the decompression was done anteriorly. And what we saw ventrally was essentially this phlegmatous granulomatous tissue that we took. It was very obvious of chronic infection. There was no frank pus, but just kind of destructive, necrotic bone and ligament that we sent off for pathology, and it came back as MRSA. And our post-op course was essentially unremarkable, with the exception of dysphagia that required an NG tube that we were able to remove successfully by post-op day 7, fortunately. And then she ultimately received a course of prolonged antibiotics. As you can imagine, this is a person who, as everybody mentioned, her follow-up is going to be in question. Her ability to fuse will be in question. And, she has a lot of other things going on, very challenging, very frail person. So in terms of the things that I thought about when I was going through this case, and just want to, again, open this up for discussion and see what everybody thinks. I think we're all pretty much unanimously on board with, we would all take this patient for surgery. I think with that degree of cord compression and her neurologic deficits, which she was probably neurologically intact, and it was really more effort limited. But with that degree of cord compression, I don't think and potentially some cortical change. I think everyone here would have taken this patient for surgery. I don't. Is there anybody who would have not? I think everyone would have taken. Okay. And then some of the questions intraoperatively, as we mentioned, anterior versus posterior or 360. If we're going to do front back, do we stage it? Do we, we did this all in one shot. But maybe do the posterior first, bring it back a couple of days later anteriorly. That's an option as well too. In terms of the inner body choice, we could use a titanium cage, which is what we used. Iliac crest bone graft is an option, as well as allograft or PEEP. Just wondering what other people would think there. In terms of if you were to fuse at C2 posteriorly, would you use a pars versus pedicle versus translaminar screw, so on and so forth. And in particular for patients who, if we were only going to do an anterior approach, and given the fact that she was a pretty heavy smoker, would we consider using BMP anteriorly? Not that we did this or would suggest this, but I just want to ask if someone has any experience using BMP anteriorly. And then post-op for her dysphagia, does anybody use steroids? And then in terms of her follow-up, how do we typically get follow-up for patients who tend to be challenging, as is this one? As we know that she has a very high risk of not returning back for a post-operative care and post-operative imaging. Is there anything, does that change anything that we do intraoperatively and take that into consideration?
Wow, Jonathan, so you just proposed questions that it usually takes a 2-day conference to discuss. But this is a perfect case. This is a phenomenon. I think this is a great case to display here, especially today, as because this is exactly the point of this, is to get different opinions. There's obviously 8 or 9 different ways to do this. And I'm just going to ask just one simple question. Did you go, how did you decide whether to go front first or back? What's your decision about that? Do you do ventral or dorsal? And can you talk to everybody about what your thought process there is?
Yeah, so for her, we decided to go front first because for 2 reasons. One, if we would be able to directly treat the kyphotic deformity, improve her C2-3 angle, and get tissue to send off for culture. If for some reason she became unstable, or if for some reason we had to abort the surgery for some reason, we at least were able to treat everything anteriorly and get that done. That was the primary thought there.
Got it. Thank you.
There's some questions from the audience. If you would, first, what kind of bone graft did you use?
Posterior, you can't really see it in the X-ray, unfortunately, but posteriorly we used allograft.
How about inside the cage?
Inside the cage, we packed it with DBM putty.
Okay.
We put vancomycin powder inside of it.
Okay. Did you use neuromonitoring?
We did not use neuromonitoring in this case.
And I don't know if we should actually ask this question, but they're asking the brand of the cage you used.
It was Globus.
Globus.
Yeah. In terms of, would anybody have not used a titanium cage out of curiosity? Would someone use maybe that class?
I think there is, personally, I think there's a, overall, at least in some of the circles we talk with, there is an increasing use of titanium cages. Certainly this, I believe this is this is a mesh cage, correct?
Yes.
It's a mesh cage. I think that's like one of the classic cages that was used for these for osteomyelitis, discitis. I think the question isn't what's the best choice of cage, but which ones are the definite no-nos? Which type of graft or cage would you say is definitely not a good idea to use in cases of discitis, osteomyelitis? John or Koi, what are your thoughts on that?
Yeah, so I think my first choice would be titanium. To your point, Ali, good evidence showing that titanium is bacteriostatic, whereas with PEEK, for example, you'll get sort of this bacterial film that grows around the implant. I think the second choice here would be to use some sort of actual bony graft, but interested to see what John has to say.
Yeah, I think that these can be really challenging situations, and I think the one consideration is not only with the hardware, but the plate and the cage in that area, high cervical. You know, it's relatively easy and common to get some type of pharyngeal perforation or erosion of the esophagus there. You know, especially for someone who maybe doesn't have the greatest medical comorbidities or is a high risk surgical patient. But I think that you do want it to heal, and so that's why I think you try to use the best type of bone graft. I do like titanium, but also will not hesitate to take iliac crest for these type of cases. Not so much structural, but morselized crest and pack it into the titanium cage. We've had some failures, and it has been reported where even with robust cages made out of PEEK or titanium, you can still get pseudoarthrosis and subsidence. And so in those cases, we've also resorted to using vascularized fibular grafts from the patient to promote healing in those situations, which has worked very well. Obviously, with vascularized fibular grafts, there's a certain degree of morbidity associated with that, not only with the harvest, but also the added time to do the anastomosis and do that. You have to have a team that's able and willing to do that. But I think that, you know, using allograft, there is data that has demonstrated that there is a relatively good percentage of resorption of the graft just because it's inert bone. And if it's not vascularized, it has a hard time healing, especially in the context where that patient's going to be on antibiotics. There's going to be a lot of inflammation in that area. And part of that may also generate a certain degree of autolysis of the graft. So,
Jonathan, there's some discussion in the chat box regarding your decision to not use monitoring. Can you talk about that a little bit?
Ideally, we would have used neuromonitoring for this case. We were in a situation, you know, we were at a small community hospital with limitations in terms of the ability to get neuromonitoring at all hours of the day. Our decision was we could have potentially waited to the morning and used neuromonitoring for this case, but we didn't want to delay. She potentially had neurologic deficits on our exam, on our evaluation, and we prefer to just go ahead and proceed with the case rather than wait for that.
Yeah, and I think that's a really good point, Jonathan, that you mentioned. I know we have like basically 90 participants here right now that are from, you know, different institutions, different regions, even different practices. It's important to, I mean, this is exactly what the point of this is. This is how Jonathan and his team doing. That's how they did it. I could tell you we would do it completely different. I would never do this case without neuromonitoring. Not that it's right or wrong, but I think there are different practices, and it's good to share that you can actually do that safely without it. But the practices definitely do vary, both institutionally and regionally. So just make sure, I just want to make sure all the participants keep that in mind.
Yeah.
John, can you comment on you and your team's decision on whether to use steroids?
Do you mean intraoperatively or
the question is in general, as well as in patients with infection.
I'm sorry, can you repeat that?
The question is in general, as well as in patients with infection.
Yeah. We don't typically use steroids at all for these cases. You know, there's some debate whether or not a patient who has spinal cord injury, if you want the methylprednisolone protocol, if you would want to use them, in particular somebody who has a low pre-procedural probability of developing complications, you know, such as like GI bleed or infection. But this patient clearly has infection, so we really don't want to put her through that. And also we're taking her for surgery as well, so we'll be able to achieve decompression, realignment, stabilization of the spine. Postoperatively, the only reason to really use steroids, I think, for this kind of a patient would be if she developed such significant dysphagia. But even then, that dosage of steroids is nowhere close to spinal cord injury dosage of steroids. So sometimes we do a very low dose, very quick taper, just to kind of get the patients through. And if the dysphagia is disabling enough where they require an NG tube, where they in some cases may require PEG, you know, we favor using steroids.
There's also a question about intra-wound steroids for dysphagia.
Oh, intra-wound, yeah. For elective cases, sometimes we'll do that. There is definitely a risk of esophageal perforation and then development of adhesions, and I know that risk is not negligible. Certainly, it's something that has to be considered. We did not use it in this case.
Jonathan, that's a great result. There was one question about the use of a collar. Do you typically, with 360 anterior posterior fixation, would you use a collar in this patient, or what's your criteria for that postoperatively?
Yeah, so we did. We placed this patient in a rigid collar. It was just really to supplement her healing process and her ability to fuse. This is a patient, again, who is very non-compliant, will have challenges. Even in the hospital, she was non-compliant with the collar. But it kind of gives us the peace of mind that we're at least doing something post-operatively that we can at least follow her, and hopefully that she stays compliant. For patients who are compliant and we would do a 360 approach, we routinely use collars on them. If we were going to go purely anteriorly or posteriorly, we sometimes place the patients in a soft collar for a couple of weeks, and we allow them to self-discontinue it when they no longer need it.
Yeah, it's interesting that there's not a whole lot of evidence behind the use of collars. One of my mentors in med school said that if he puts a brace on a patient after surgery, it means he hasn't done a good enough job instrumenting them. I tend to use it in select cases, mostly as a reminder to patients to sort of take it easy for those first several weeks. But I don't think there's a lot of evidence one way or the other.
Yeah, that's a great point. I mean, I did my fellowship at the Cleveland Clinic too, and I honestly, there's so many great pearls I learned there, and I forget who I learned it from, but one of them just kind of said, it's kind of like depending on the patient, it was kind of like a penalty shot, so just depending on the compliance of the patient and what they look like. Maybe it was Calphus, I don't know, but he said that it was kind of like it was like a penalty for for the things that they bring to it, just thinking how they're going to comply with instructions. Yeah. So you're right. There's the evidence isn't great.
Yeah, that is Dr. Kalfas, by the way, but he was not the attending for this case. But very quickly, I know we're running out of time. Just a couple of relevant papers I picked out just for this case. If you guys want, I can send an email out to the group with the actual citations, or you can just screenshot the screen and you can just see these. I like these articles a lot. This is one that was recently published by Thomas Jefferson University, looking at the difference between a pure C2 pedicle screw versus what they termed a parsicle screw, which is essentially a screw placed at the entry point of a typical pars screw, but traverses the length of the pars and the pedicle of C2 and ends at the normal ending point of a C2 pars screw. And they really go through the technique, the differences between them, and kind of how they do this. And that's what we ended up doing in this case. It was a parsicle screw. It wasn't a typical pedicle screw. And these are just some of the things that you have to look, and if you're going to go ahead and do this, a parsicle or a pedicle screw, some of the things you have to look at the imaging and really analyze it preoperatively to make sure that the patient has a good pedicle that can accept a screw. The two things they want to look for are a high riding vertebral artery, which you see that on the bottom left-hand image right here. And these are some of the criteria of a high riding vertebral artery. Or you look for a narrow pedicle. And if you have either one of those two, they usually coexist. But if you have one or the other, it may make a pedicle or a parsicle screw very challenging to place. So just something, if you're going to do this, really look at the imaging pre-op. And in particular for the residents and the medical students, if you kind of know some of these things, it makes you look really good when you're talking about this case with an attending. This is a relatively larger study looking at the outcomes for the routine use. They didn't use this in trauma or in infection of ultra-low dose BMP for cervical corpectomy. What they found was that in a cohort of about 24 patients who were all very challenging patients, these are not like routine cases, these are patients who are mostly smokers who had very high pretest probability of developing pseudoarthrosis or other complications related to anterior cervical corpectomy. They used ultra-low dose BMP, which is technically 0.25 milligrams per ml per level. Other publications for low dose BMP are much higher than that. As you can see, I put that up there. And they did have some complications. There was almost 20% rate of adjacent segment disease, subsidence, and heterotopic ossification, but none of those patients required revision of those. And there was very significant dysphagia and hoarseness after the surgery. So what the authors here recommended is to place all these patients on a steroid taper after surgery. So they questioned the ability of this to be routinely used for reoperative cases in patients who already had a history of osteoarthritis, and in potentially in patients who have infection and cancer. But then again, BMP for infection and cancer is a very pro-inflammatory substance. It's very, very iffy whether or not you would use it. Probably would not recommend to use this in this case, but I will circle back around to see if anybody has experience using BMP. I would really like to hear about that because I personally never used it anteriorly. And then this is a recent study by Dr. Trainellis about his experience over at Rush. And this was basically everything, a 360 cervical fusion, everything done intraoperatively at the same time. These procedures were not staged, and that's why the reason I asked that. As you can see, and these were routine, these were not for trauma. As you can see, the complication rate, both major and minor, is not insignificant. It's pretty high, and pretty decent amount of these patients required continued, or rather they had a prolonged length of stay due to postoperative dysphagia. Some required NG tubes like ours did. Some required a PEG. Some significant percent of the patients required a trach. And as you can see, the risk of an adverse event such as a pneumonia, UTI, wound infection, or reoperate was not as significant. So the authors of this study said to seriously consider the complication rate in patients who are at risk of developing a complication after a one-time 360 fusion, and kind of keep these things in mind. Consider staging it potentially to potentially avoid some of the risks here.
Thanks again for joining us, and we look forward to hosting you next Thursday, 5 p.m. Eastern Time, for another episode of the Virtual Global Spine Conference.